Hello, hello,
हेलो
hello, hello,
हेलो
hello, hello. Hello, hello. Before starting this event, I would request to all the students, please kindly put your phone on silent. We make a living by what we get, but we make a life by what we give. This is a very famous quote said by Winston Churchill.
Good morning, everyone. I am Miss Archana, Faculty of Psychiatric Nursing, accompanied by Miss Supriya, Faculty of Psychiatric Nursing, on behalf of Indira Gandhi School and College of Nursing. Welcome you all to this important seminar on palliative care. We are so glad to see so many participants who have come together to enhance our knowledge on such as a crucial aspects of healthcare.
We are highly grateful that for today's event, we have been joined by our esteemed guest, Dr. Mariama C. John, Principal of Sultanpur Institute of Nursing and Paramedical Sciences. Additionally, we have our special guest among us. I would like to welcome Dr. U.S. Siddiqui, Principal of IGIPS, Mr. S.J. Singh, Vice Principal of IGIPS, Mr. Avdesh Sharma, COO, Mr. Suresh Kumar Singh Rajput, Sir, Admin Manager, Mr. Sarvesh Sharma, Sir, OT Manager of SGH. I also welcome Principal of IGS Con, Dr. Ramesh S., and Vice Principal of IGS Con, Mrs. Gomti M. Ma'am. Dear audience, we are about to commence our event by the lighting lamp of knowledge and wisdom that signifies the dispelling of darkness and ignition of thought and enlightenment. So, I request our esteemed guests to kindly come and light the lamp. Meanwhile, I would like to call Ms. Shubham and Ms. Shivani for prayer song. I request Ms. Shubham and Ms. Shivani to kindly come for prayer song.
निकार दे तू मैया बीड़ा की मधुर वाणी अमृत सा ज्ञान बरसे मकर हम पे मेहरबानी झनकार दे तू मैया बीड़ा की मधुर वाणी अमृत सा ज्ञान बरसे मकर हम पे मेहरबानी जिस स्वर्ग में दूरमी है उस जग में क्या कमी है जग पूजता है जिसको उस जग में तू रमी है झनकार दे तू मैया बीड़ा की मधुर वाणी अमृत सा ज्ञान बरसे मकर हम पे मेहरबानी.
Thank you, Ms. Shubham and Ms. Shivani.
It gives me immense pleasure to welcome you all in this momentous occasion. We are truly honored by your presence. Hence, I would like to call Ms. Piyush, student of MSc Nursing second year, to welcome this gathering.
Good morning. I am Piyush Kunjan Yadav from MSc Nursing second year. Everyone, it's pleasure to welcome you all, respected chief guest, guest of honor, principal, vice principal, distinguished speaker, faculty members, and dear colleagues and students. Is it with great pleasure and a deep sense of responsibility that I welcome you all to this important and insightful intercollege seminar organized by MSc Nursing batches of 2022 to 2023, 2023 and 2024 here at Indira Gandhi School and College of Nursing, Munshiganj, Amethi. Palliative care, as many of you are aware, is a holistic approach that aims to improve the quality of life for patients and serious life limiting illnesses, as well as support their families. It is an area of healthcare that required immune compassion, special knowledge and skill, and this seminar provide an invaluable opportunity for us to gain deeper understanding for its essential principles. I would like to express my gratitude to our esteemed welcome, our administrator, retired Wing Commander Mr. Manoj Muttu sir, and our director Madam Sarmila Rai Chaudhary ma'am. We welcome you ma'am in your absence. I request our principal sir to please facilitate our chief guest Mr. Dr. Mariamma C. John, Principal of Sultanpur of Nursing and Paramedical Sciences, for your gracing us your presence here. We welcome you, ma'am. I request to our Vice Principal, ma'am, to facilitate a special welcome to our Great of Honor, Mr. Dr. U.A. Siddiqui, sir. We welcome you, sir. I request to our Vice Principal to welcome our Admin Manager, Mr. Suresh Kumar Singh Rajput, sir, Sanjay Gandhi Hospital. We welcome you, sir. I request to our Principal, sir, to welcome Vijay Tiwari, sir, from IGIPS. We welcome you, sir. I welcome today's eminent speakers of this seminar. Day first, Ms. Divya, Ms. Harshita, Ms. Priyanka, Ms. Shubham Maurya, and Ms. Piyush. And day second speakers, Ms. Archana, Ms. Divya, Ms. Neetu, Ms. Shivani, and Ms. Supriya. It's our immune pleasure welcome to the distinguished members of administration and our principal, vice principal, and faculties of IGSCon, and also thank who have supported this seminar. Your encouragement and commitment to advising nursing education and healthcare are truly inspiring. Over the next 2 days, we will be hearing from an incredible lineup of speakers who are expert in various aspects of palliative care. We will explore topics ranging from communication skill, pain management, emergency in palliative care, ethical consideration in palliative care, and end of life care. We hope that this seminar will provide not just knowledge but also inspire us to carrying forward the value of compassion, empathy, and professionalism in our practice. I would like to take this moment to thank all the participants and organizers who have worked patiently behind the scene to make this event possible. Without your dedications and hard work, this seminar would not have been the success that we know it will be. Finally, I encourage each of you to actively participate in our session, ask questions, and engage in discussion. The more we learn, the better prepared we will serve those who need us most. Again, welcome you all to enriching seminar. Let us make the most of these 2 days so we deepen our understanding and knowledge of palliative care. Thank you.
Thank you, Miss Piyush.
Palliative care is a specialized area of healthcare that focuses on providing relief from symptoms and suffering of serious illness. It improves the quality of life for both the patients and their family by addressing not just the physical but also emotional, spiritual, and psychological aspects of care. Today, we have the honor learning from some highly experienced, knowledgeable speakers who will share their insights on this vital topic. Moving further, we have our honorable guest among us, who is a beacon of knowledge, brilliance, inspiration. We are truly honored to have the opportunity to hear your enlightening words. Without further ado, ladies and gentlemen, let's put your hands together for respected ma'am, Dr. Mariama C. John.
Very good morning to all respected guest of honor, Siddiq sir, Managing Director sir, and Professor from Indira Gandhi Paramedical Science, Principal of sorry, IGS Con, Ramesh sir, and Vice Principal Ma'am Gomdi Madam, all the distinguished guests who are resided over here, and the students. It's my privilege to be here today, and I really congratulate the initiative which you have taken to start this intra college seminar on palliative care. As you know, palliative is something, is a specialty of the medical service which is provided to the person, those who are in the terminal stage. But we think that terminal stage means that we are going to end the life. No, actually it's not. It's only to alleviate the suffering of the people. Those who are already been or been separated, or they know that they are going to end their life, they are not going to have any more prognosis in the life. So people more than the physical illness, what they think is, oh, it's over, my life is over, no more I am here. So there is a sort of stress which build up in their mind. I think we need to support those people to relieve those stress rather than the physical pain only. For example, if a person who is being diagnosed with the last stage of cancer, they think, even the society also think that, oh, it's over, no more, no hope more. But no, we have to put them, we should bring some hope within themselves before they end the service in this world. They may have a lot of ambition in that is left behind, not been completed, they are incomplete. So what we need to, as a nurse, because nurses are there 24 hours a day to support patients or people, rather than the other medical professional. They might come, they will just visit for a few hours, they may recommend certain medicines or treatments or some investigation and they leave. But nurses are there for 24 hours a day. So nurses should know that these persons are not only suffering from the physical issues, they have lot of stress, maybe stress from the family life, maybe the responsibility that not been handed over to someone same like the responsible person. So all the stresses are keeping them in more panic situation. So even though the life expectancy is left for few days, but they might leave as soon when they hear this shocking news that they are in palliative care. So what we need to do as a nurse, we should always support the patient. There is certain principles in palliative care. I am not from medical surgical nursing, so I cannot talk much about on palliative care. I am from a child health nursing, so childs are growing population. They have lot of ambition, they have so much to explore this world, but adult, they have already seen the world, so they might not be. So I am not talking much on that, but my I need to address this palliative care. I think the principle might be communication. I think communication is a lacking part in Indian nursing service or Indian medical service. I have experienced by myself. I've been I think few years back I had a problem with my shoulder. It was locked. I went to a doctor. He did not even talk to me. He just asked what happened. I said, like, this problem I have. So what did he do? Just put an injection into my shoulder, intraosseous injection. Did not even talk to why he is going to. As a patient, I have all the right to know why they are doing that treatment. So that part of communication is missing in our India. So I think whenever we are looking into palliative care, we need to discuss. We need to communicate with the people. As a nurse, you one of the most important part of your care itself is communication. Communication can take away a lot of suffering from the people, because they might be full of questions within themselves, why this is happening, what is the next step that I should do, or what the doctors or the nurses or healthcare team is going to do on to me. So all these things are within the questions of people. So I think communication is very important. As you know that the local language, most of the time people are talking, so you are very expert in that. So better talk to the patient, let them relieve their stress, their pain. Not only focus on the physical aspect of the care, but also look into the psychological aspect. And then compassion. Compassion is also important. Nurses, most of these days, I don't know how many of you are here with the compassion to care for a patient. Most of the people, student nurses, when they come to us, when you ask why are you choosing this nursing as a profession, they never say that because they want to care for the people, those who are suffering. Most of 50% of people say it's from the force of the parents. They are forcing because it's very easy to have a job after completing your degree or master degree course, that may be or diploma, or other people they say because they couldn't get in medical field, so they chose nursing. So it should not be in that, it should not be of that type of answer. If when you are a nurse, you have to care for the people. And while I was entering into the campus, I saw cure with heart. I think it's there, the level of that your keynotes is there, no? Care with heart, as a part of your Sanjeev Gandhi trust. But I think care with heart, when it comes from your heart. So I think it's always necessary you care from your heart, so that we can cure with heart. With this word, I will end my message. Thank you so much. Thank you again for inviting me to this initiative of this seminar. Thank you so much.
Thank you, ma'am, for addressing this gathering by sharing your golden words.
Ms. Supriya, as we speak about palliative care, we cannot neglect the father of palliative care. In 1974, Dr. Balfour Mount, surgical oncologist from McGill University, coined the term palliative care to differentiate it from hospice. From there all it started. And now I would like to call Mr. Suresh Kumar Singh Rajput, Admin Manager, SGMT, to kindly come and share the dais with us. Please come, sir. Sir.
Kanpur, and Dr. Siddiqui sir, Principal IGIPS, Dr. Suresh sir, Gomti ma'am, all professors, associate professors, faculties, dear students. I first welcome to ma'am. She came from the Sultanpur, saying about this program. Palliative cares का मेरे को अभी तक मैं actually I didn't know the much about the medical field. I am the general this thing. तो मुझे अभी तक यही समझ में आया है पैलेटिव केयर्स का मतलब है कि हम लोगों को जो भी काम करना है, कोई सीरियस पेशेंट भी है तो उसको ये नहीं बोलना है कि तुम्हारा कुछ नहीं हो सकता है, ये है वो, उसको हीलिंग करना है, उसको मोटिवेट करना है, सो दैट के अंदर से वो जीने की इच्छा जागृत होगी तो वो नेचुरली ठीक हो जाएगा। इसके लिए एक छोटा सा उदाहरण है। अभी रिसेंटली जो अपना कॉमेडियन उसमें जो आते थे, उनकी वाइफ को कैंसर हुआ था, सी इन द 4th स्टेज, बट ने मतलब इस तरह का मतलब वो मोटिवेट करके और जो मेडिसिन वगैरह दिला के मतलब आपको कुछ नहीं होगा, ठीक हो जाओगी, और नेचुरल अभी उसने जब टेस्ट कराया तो वो ठीक हो गई। तो कहने का मतलब यही है कि मुझे कैसे बताया है कि हमारा जो प्रोफेशन है उसमें हमको बहुत ही दूसरों के इमोशन को देखते हुए काम करना है। ऐसा ना हो कि किसी को और हर्ट हो जाए, जो कल मरने वाला वो आज ही मर जाए, ऐसा नहीं है। तो हमें मोटिवेट करते रहना है टिल जब तक उसका हो सकता है कि उसको आपके मोटिवेशन से किसी की जान बच जाए। तो थैंक यू वेरी मच फॉर गिविंग मी दिस अपॉर्चुनिटी। थैंक यू।
Thank you so much, sir, for sharing your views. Next, we would like to request Mr. U.A. Siddiqui, sir, Principal of IGIPS, to kindly come and motivate our speakers.
Hello, good morning to all of you. Respected Nursing College Principal, Principal from Sultanpur Nursing College, Vice Principal, and Mr. Srachin Rajpuji. I'm very glad to attend this conference, and nursing profession is a very noble profession. Florence Nightingale gave respect to this profession. Previously, people from very low class, they went for nursing. Now, Florence Nightingale, she belonged to a very high family, and she chose this profession. So she gave respect to this profession. Finally, I want to say that doctors, they are very busy. They just come and take BP, pulse, ask governor what is her position, and they just prescribe. They have no time. They have to attend a different patient. But nurses, they are always there. They provide all the injection, all the medicine and advice. And by their smile, most of the patient they cure. तो हम ये कहना चाहते हैं कि ये पैलिएटिव केयर जो है ये मेडिसिन के अलावा है। मेडिसिन के अलावा है, उनको थोड़ा समझाना है, थोड़ा ढाल बांधना है, थोड़ा उनको और समझाना है कि भाई तुम ठीक हो जाओगे। अगर जैसे लास्ट है, कैंसर है लास्ट है, उनको थोड़ा समझाना है कि दवा अच्छी हो रही है, सब लोग देख रहे हैं, इस तरह के पेशेंट ठीक हो जाते हैं। इस तरह से जो है उनका थोड़ा इंकरेजमेंट होगा, तो मोरल बूस्टिंग होगी, इस तरह ठीक हो जाएगा। नर्सिंग प्रोफेशन को यह है कि थोड़ा चिड़चिड़ाना नहीं है। पेशेंट जो है वो उल्टा सीधा बोल देते हैं, कह देते हैं, उनको बहुत पोलाइटली जो है डील करना है। यही मेन क्वालिटी है। इसे पेशेंट धीरे ठीक भी हो जाएंगे, तो बाद में कुछ ना कुछ आपको गिफ्ट दे के जाएंगे। तो ये मुझे कहना है।
Thank you so much, sir. When Ms. Archana quoted about the alienation palliative history, we have an ancient tradition in India for special care and attention for those who are very old, healing for dying. The 18 institution built in India by King Ashoka in 273 to 232 BC, in which one had the characteristics very similar to modern hospices. Moving forward, this session will be incomplete without the words of our respected principal, sir, Dr. Ramesh S. So put your hands together for principal, sir.
Respected SGMT trust members and respected SGMT administrator and CEO of IGI and respected admin manager and respected principal, vice principal of IGIPS and faculties and as well as students. We are really very warm welcome to you all and special guest Dr. Mariam C. John from the Sultanpur Institute of Paramedical and Nursing Science. We are really warm welcome you be a presence of our group of IGI under the trust member of AGMT. Really, we are very much happy to be here and honor for each and every dais and my dear students and faculties. Here, I am taking the very much immerse to honor our AGMT trust, what is doing here. It's very much focusing on the good education want to give for the rural community children. This education is a lightning for the life of the rural children. They cannot able to get the opportunity to welfare of the nation as well as the global. So right now we are very much taking the immense pleasure to thankful to the trust member as well as administrator and the CEO of the Indira Gandhi group of institutions. And I will congratulation to the MSc Nursing, the batch 20 to 23, 23 to 24, 24 to 25, all together. They are putting the very much initiative and want to organize this intra-college seminar. Is really very much lifting for their institution, the way of educations, how much the we are background of all the support of the faculties, all the group of institution of our IGI. Here, I want to say or share something about the palliative care. Palliative care is a very essential right now. One point I want to quote it here, the worldwide, the total population, 8.2 billion. In this, out of 8.2 billion, out of 3 in 1 person is affecting the chronic illness disease. Then you see how much the population are affecting the chronic illness disease. The chronic illness disease is nothing but the end of each and every human life, end stage of life, like brain death, stroke, heart disease, lung disease, as kidney disease or liver disease, life threatening of the disease of cancer, HIV, as well as AIDS and geriatric disorder, delirium, dementia. These are all the disease quoted indicate of that they are the no hope of life. That's all. हिंदी में बताने के तो गया गया मर गया ऐसा बोलते रहेगा. Actually, palliative care is giving the total care. There is no hope for end stage of the human life, but giving the hope to again a rebirth of their life with multiple care of the physical, mental, social, spiritual, all the things will give the hope to each and every end stage of life, showing the lightning of life. Still, you are not going to die. Still, you are going to alive with the help of health team members. That's why today you and me, we are the very much proud of people. Why? Because we are not dealing with the mechanical life. We are dealing with the human life. So we are not dealing with the mission. We are dealing with the live mission of human being. Today, this much of precious, you are sitting here and learning. Why? Because this is the life of education. The education can do anything. That's why, as like today, we can say very much proud of nursing profession. Nurses can do with help of even 1 day or 2 day or 1 minute or 1 second. You are extending the patient life. You are the challenging or you are the precious one. Our administrator, SGMT, wing commander, retired commander, Manoj Mittu, always he will say, the nurses is in my heart. Why? When I was suffer in the health issues, that time nurses with me and they caring, I saw through my eye, not eye, through my heart, I saw the nurses is only the warrior to backbone of the patient. And he is one of the role model. That's why he is not his highs of the Indira Gandhi institution, group of institution. He is a heart of Indira Gandhi group of institution. That's why today this much discipline way of education want to give to through the Indira Gandhi group of institutions. Everywhere getting educations. That is the education. But here the discipline with education make the perfection of in your life. The perfection only will come through to the end stage of our human life also, have the life to bring it out each and every individual. That's why now we are very much, I'm thankful to all the dais as well as my dear faculties and students. Really, the palliative care, the very essential care, because in India, the population almost 142 crore. According to the statisticals of the 2024, we are the highest population in worldwide. We are achieved, but still we are not achieved growth of our economic. So these are all the things we'll achieve through the lightening of education. Education, especially for nurses education, is a backbone of the country, backbone of the global, backbone of the heaven. That's a very important point. Even you see in India, proudly can say the nurses, through the nurses, the economical growth is going to leading the highest growth in worldwide in 2050. But no one country can achieve this one. Why? Because nurses, through nurses going to bring it out 2050, you see the globally the economical growth going to increase. Which country they are producing the highest nurses? That nurses is the backbone of the palliative care. The palliative care is extending to the life of the each and every human, the dying situations. You see, everyone are achieving, they say, but true achievement, one man in a life-threatening situation, you extended 1 minute, 1 hour, or 1 day, or 1 year, or 100 a year, you're extending. That is everlasting life. It's only possible through the nurses. I can say very much proud of nurses to encourage in each and every the patient when I was sick, they will go to take me alive. Even died also, they can able to bring it out with the help of the love, affection, empathy, sympathy, and quality of nursing care can able to bring it out. Only the medicine can react only certain time, but the nursing care will react 24 hours, 365 days. Will be a walk. Medicine will work for only 20 minutes, 30 minutes, or 1 hour, or 2 hours. But the nursing care will be 365 days, 324 hours. 3 bar into 4, 24 hours. It will be walking. It will be react. Just bring it out in the rebirth of their life. Even you see each and every in the family, mother is a nurse. Okay, the like that you see each and every family also one nurse is there. The mother is caring to their baby. As like a nurse means not only for caring of patient, the caring of husband, caring of their children, caring of the society, caring of the nation, caring of the global. Many people are thinking nurse means only nurse, only caring for only hospital, certain things. It's not like that. The nursing care, each and every house, the family members are there. So that's why today really I'm saying that you can think it about yourself. Your profession is a very much dedicated profession, disciplined professions. So you be and courage to keep your willpower, then automatically through you, you can able to show your profession or professionalism. Then it will come to bring it out the end result of the successful result. You have proudly say nurses can save the patient life with nursing care. Jai Hind.
Thank you so much, sir, for your motivational words. Now, I will introduce our first speaker, Ms. Divya Pandey, student of MSc Nursing second year, batch of 2022-23, who will provide us with some knowledge of communication skills for palliative care.
Morning, respected chief guests, all the teachers and all the dignitaries, as well as all the students. I am Divya Pandey from MSc Nursing second year 22-23 batch. I am very thankful and honored to share this stage in front of all the mentors who are present here. Today, as we are dealing with the palliative care, so I am the first speaker and I will start with the palliative care and I will leading my presentation with the communication skills for the palliative care. Why communication is most of the important thing in the palliative care. As a nurse, we should develop a proper technical skills to talk with our patient, because communication is the first tool to heal our patient. Because if we will not talk to the patient won't able to tell their things to us. Communication skills for palliative care. Before dealing with my topic, I would like to tell you about palliative care. As many of our mentors and teacher, principals, and ma'am already had been told about the palliative care. Sorry. That first is general objective of my presentation. At the end of the session, the student will enhance their knowledge on the palliative care regarding communication skills for the palliative care and change their attitude in a positive way and can utilize these skills and knowledge in further when they are going for the clinical postings in our hospital or outside of the hospital, as well as in the community posting when they are visiting to the community area, village areas, urban and rural community. That time they will be know what are the communication skills are. Specific objectives or general objectives. At the end of the session, the student will be able to know define palliative care, describe communication, define what is the need of communication skill, describe why communication skills are important, describe effective communication, explain the need for effective communication, enumerate the steps of effective communication, describe the steps of communicating bad news, describe how to deal with the pollution. These are the topics which we are going to deal in today's presentation. So, first, definition of palliative care. According to WHO definition of palliative care in year 2002, palliative care is an approach that improves the quality of life of patients and their families facing the problem associated with the life-threatening illnesses through the prevention and relief of suffering through early identification, impeccable assessment and treatment of the pain and other. What is the palliative care means? When the person or the patient is dealing with the life-threatening condition, serious disease condition, palliative care is not limited only to the cancer patient. It is for all the life-threatening conditions when a patient is dealing with, then palliative care is needed. So here I'll start with my topic, that is communication skills for palliative care. Communication is exchanging idea or feelings between two or more people on a common background or agenda. Communication can be verbal or non-verbal. The communication process is complex and more than 70% of communication occurs through a non-verbal means communication. When we do communicate, we'll exchange our idea. It will be between one to one conversation or communication, or we are talking in a group. For example, now we can take, I'm talking with the all group, so it is one way communication, but this is also a type of a communication. When we are also communicating with our patient, first and foremost thing, we should be clear it out that conversation is not communication skill. Okay, what sometime will get a wrong idea that when we are communicating or having any conversation, that is known as communication. But a communication need a skill. Like we need a practice. We need to practice. We need to develop in that. Then only we'll be capable of getting a proper communication techniques. Good, good communication is a trainable skill. Proper communication is vital for well-being of the patient and the family and satisfaction from work. Studies shows a significant unmet communication need for information about the disease, prognosis, treatment options, intent, side effect, and complication. According to this, sometime it is happening we are in so hurry. We are not attending our patient well. So when patient bystanders or family and coming asking us ki, whether our patient is okay, the condition is recovering or not, what medicine, why they are giving the too much medicine, then we used to tell, ठीक है जाओ आप बाद में बताएंगे. That is not a proper way. We need to stop with them. We need to communicate properly. We need to explain and we need to give a proper information to the bystander as well as to the patient. Because when we are not imparting the proper information, the problem, the stress, the depression, their tension will increase that time. Because sometimes we used to talk in a front of in our language, jargons will be there in medical language, then patient and family will think something big is there, our condition is very worse, we are not going to recover. That will increase the tension and stress in the patient, and that will interrupt to the healing process of the patient. So always be a nurse who, if you don't have time, you can explain to them, wait for 5 minutes, I will be coming back from this work and I will explain what is the thing is there. So this is the proper way to communicate with the patient. If you are not communicating like that, you won't be capable of making a proper rapport with your patient. Then patient won't be sharing their information and the treatment or management process won't be proper. What is the need of communication skill? Why we do need communication skills? Good clinical communication will help the patient to express his need to the treatment team better. It helps clarify doubts and baseless apprehensions. The therapeutic rapport that develops through the effective communication supports the patient and family to handle the emotional responses to the illnesses and deal with the uncertainty. Why we need communication skills? Sometime, like when you are visiting to the hotels, after coming back from there, you used to tell her that receptionist was very good. She communicated everything very nicely. When we had a phone call conversation in our room service, that was very good. They are also being trained. So like that, nurses also should be trained and there should be a proper rapport. How we can make rapport with a proper conversation, and this conversation should be a therapeutic conversation. Means the conversation which is the main goal is to treat the patient, because we are talking with the patient. Why? To know about the patient, to know more clear about the patient, because sometimes the patient won't share much things with you until and unless you are giving the proper time to the patient. You don't directly don't like blame the patient for anything. Don't compare the patient with anyone. Just talk and just listen to the patient carefully. Sometimes when you are telling your thing, patient won't tell his thing or her thing. So patience is very much needed as a nurse for listening the patient. Sometimes irritated patient will be there, but you have to be in a peace. You need to listen them peacefully. You need to consider each individual patient. Like you had been studied the psychologies, everything, so you can understand the patient condition. You can keep yourself as them. When your family member will be there, what will be your response? So you also need some information. So next we'll describe what is effective communication. The therapeutic rapport that develops through the effective communication supports the patient and family in managing the emotional responses to the illness and dealing with the uncertainty. The nurse understands the shared and balanced decision to be evolved based on the patient values, beliefs, and priorities, yet support by the clinical evidence and the rationale from a caring treatment team. Effective communication, as well as when we are talking with our patient, we should not tell like our beliefs, our values. We should listen to them, and we should also consider their beliefs, from which religion they are belongs to, what values they are, what things they are following. So we also need to consider, but along with that, we should have a proper rationale behind treatment and management, or whatever care we are providing to the patient. There should be a rationale, there should be a research, there should be a evidence proof that for what, why we are doing, we do have the evidence for this. Here the some tips for effective communication in palliative care. First is to build rapport. As I said many times, build rapport means a nurse patient relationship should maintain, and it should be a respectful relationship that we also called as a therapeutic relationship. For that duration of time, when we have to treat from the patient the time admission came till the discharge, that rapport and the therapeutic relationship has to be maintained with the patient. Use simple language. As we know, when we are visiting to the patient, local patients will become, they don't know English, though they don't know even like what we used to talk. So हमें क्या करना है? We need to talk in their own languages. Okay, what from, usually we are from the nearby only na, so we know what local language they are using, so it will be very comfortable for them. They will be comfortable, and they will be they will be sharing more things to you. So you will be getting more ideas, getting more things, and the management process and treatment process will be more good, because you are understanding the psychology of the patient as well. If they are having any tension, any stress, they will share with you everything. So this is very important to use a simple language. So avoid the medical terms in the front of the patient. Sometime it will be happen to the first year student, when we used to learn many new things. Now we'll go to hospital, and we with our friends will stand nearby to the patient bed, and will talk in our medical terms. Okay, so avoid those things when you are visiting, or we are going for the duties to the hospital. Stand one by one patient and talk to them by their what they are feeling, how they are feeling, whether they are feeling okay today, what they had in night, last night supper, what they had. So like this conversation we should have directly. We should not go to the patient and tell vitals lena hai aapka. You used to tell like that na ki sister ne bola, then I have to take your vital, that's it. First you have to take consent of the patient. You should tell to the patient. This is a communication skill, why it is important to you. This is not for our benefit, this is for your benefit. You have to check this. So like this politeness in your language has to be there, as well as you should have a peaceful mind when you are visiting to the patient. Next is practice active listening. You should have capacity to listen the person. Sometimes words will be coming in your mouth, and you are trying to speak it out. But you need to wait. First, you need to listen to your patient. Then you should tell your thing. Be honest and transparent. Don't tell any wrong things. Don't tell any assumptions. Okay, so be honest, like whatever the thing is there. If bystanders are there, family members are there, you need to be transparent. Don't hide the information from the family or patient. If patient is very critically ill and the family had been told, don't directly tell the things to the patient. Then there should be information imparted to the family members. It should not be hidden. Anything should not hide from the family members. Next, here is the some. It is a continuation. Next is use appropriate body languages, like the posture we are doing while doing the procedure. We had been studied in first year body mechanics, and the way we are standing, the way we are walking while doing the work, while doing the procedure, while doing the visit, while visiting the patient. We should not like sit on the patient bed, sitting like this. We should maintain a proper posture of ourselves. It should be a representable. It should be a professional. It should be a look good. Next, ensure privacy and confidentiality. Privacy, like whatever things patient are sharing with you. Like if patient share with you anything and you are going and telling to your friends, other staff members, and laughing and making fun of that patient. So it won't be good. And whatever the information or their person, sometimes patient will share you many things and they will tell you don't share to my family members as well. So you need to make that information confidential. You don't need not to share to anyone one else, whether it is your staff, doctor. When you think this information is much needed for the treatment, that time that information has to be given to the doctor or the senior nurses, but should be confidential way. If the patient had been told you to keep it confidential. Next, collaborate with the healthcare team. It is well known that without a team, we can't work. A single person in a hospital cannot work. A doctor alone can't work. A nurse alone can't work. So a health team needed. And when we are going to care for a one single patient, a full team is needed to provide a full uh, holistic care to the patient. So teamwork, coordination, management, proper communication among the team is also very important. Need for the effective communication. Effective communication is essential in palliative care for several reasons as well. Patient oriented care. The patient oriented care, the main focus will be on the patient. It is all around patient care, means how their full routine, their treatment, their management, medication, how they are feeling. Everything will be oriented to the patient. That is patient oriented care. Quality of life. Quality of life means we need to give a type of a care which will enhance their quality of life. We will motivate the patient. Okay, we will tell the patient, like some patient will be at the end, it will be depression for the patient. So we need not to say like it is going to be in. We need to motivate like patient. We have treatment. We are ongoing treatment. Your like progression is there. It will be okay. Like this, we need to have a conversation with the patient and the decision making. Decision making also communication is important. Why? We can take decision when we do have some information. So before that, we should collect the proper information. We should communicate with our team member, and then decision has to be taken. What need to be done further for this patient, or on this situation, what thing has to be done. Emotional support. Emotional support in a palliative care or a palliative patient or highly life threatening condition patients are there, then we need to be empathy should be there, not sympathy. We could not tell the patient आपको तो ये हो गया, कोई बात नहीं, ठीक है. We should not tell like this. We should be have empathy. We should keep ourselves on the shoes of the patient, also feel like them. So we should have this quality and the coordination of care. Coordination means teamwork should be there. Like everyone should know at what time what they have to do, what is the schedule of the patient. So it can also come when you have a conversation with your team, when you have the proper skill of communicating. Like sometimes we do communicate, but it won't be polite. It will be hurting to the others. So that is the skill we need to develop in ourselves. When we are telling anything, it should be polite, it should be good, it should not hurting to others. What if we fail to communicate? We are not we had not developed a proper skill to communicate, then we are not achieving it. Then what will things can be happen? First, it may lead to the poor symptom control. Like patient will not tell anything. We will do the hospital will do, or the doctor will, whatever they are seeing, or what investigations are there, on that they will do the management. Treatment will start, medication will start, but sometimes patient will depressing inside. That symptoms will increase and we won't be capable of controlling that symptoms because we are not talking with our patient. The patient may not follow the plan of care as their needs agendas have not been discussed and supported. That is same thing. We don't know what are the need of the patient. So we won't be capable of fulfilling those agendas or those things of the patient. Next, the adjustment to the illnesses and interventions would be poor, and this can lead to the worsening distress. Means when we are giving medicines, the positiveness of the patient is also needed. If patient is not positive and patient is not responding to the treatment, the medicines also won't be work, because medicines will work on condition, but their mental, their psychology, they do have to enhance, they have to work on that. If they are not, like every time they are telling I'm sick, I'm sick, I'm sick, some person will have big accident, even though are happy, they are talking to everyone, someone will have a small cut and that time they were having a severe cry and everything. So that is also, we need to support our patient, need to communicate well with our patient, give a support, emotional support to the patient as well as to the family members. The team that does not communicate effectively may find an inquiring patient too demanding. This can be affect the therapeutic relationship. Therapeutic relationship should be proper. When we are skipping anything in between maintaining a therapeutic relationship, sometimes the needs of the patient won't be met. Then we won't be capable of planning our full way of care and won't be able to provide the full way of care. Medico-legal problems stem primarily from the poor communication and misperceptions and misunderstandings may ensure. When we don't know about anyone, sometimes it will be happen between our friends also. When we are not talking, sometimes misunderstandings will be there. So it is happening with the patients also. So when you are going to the ward, what you are doing? Just taking a tray and taking the vitals. It should not be there. First of all, you go and visit your patient, greet the patient, then tell your routine is not been done. So I'll start with the vital signs. So be like that. So you will also enjoy your work when you are going to. Sometimes you will feel like it is like burden to us while going to the posting. Here posting, there posting. Every month we are having posting. When you enjoy your work, okay, when you enjoy the patient's company, you are working with, you enjoy. That time you won't be feel burdened to go to hospitals. Next is communication skills. Effective communication skills are essential for nurses who are critically in providing high quality patient care. Nurses must be able to communicate effectively with the patient, families, and other healthcare providers to ensure that the best possible care is delivered. Nurses need to acknowledge and understand the concern of the patient and family and respond appropriately to bring clarity to their current situation. Means effectively they should be capable of conversating with patient, family members, with the health team members and the person who are working in their hospital. They should know how to impart the information. They should know how to approach to the higher authorities. They should know how to give the information or any bad news to the family members. They should tell like recovery is not possible. We need to refer the patient to the higher center. They should like nurses should have the capability and should have the skill. From that fourth thereby, that's why you are giving the assignments, health talks are being given to you. You are presenting to the patient only, no? So in this also you are developing the skill, how you are greeting the patient, how you are approaching the patient, how patient for doing the procedure you are asking the consent from the patient, their willingness, their consent. This is also type of communication skill. Sometimes you used to say, ma'am, when you are going, the patient is ready to take the care or any procedure. When we are going, they are saying no. Then why? Because you have to develop that communication skill, that approach, how to approach the patient. These are the some skills. First is active listening, that you have listened to the patient. Then empathy, you should feel what the patient is feeling, not sympathy. You should not say like poor you, or you got this condition, or this is worse condition. You should not tell like this. You should feel the pain of the patient. That is empathy. Clear and concise communication. Do not make the stories. If patient is asking anything, it should be clear, short, concise. You should not tell like you came that day, you were like that, today given medicine, so you are like that. Don't make the story. In this, the patient will become confused. So you need to your information or your statement should be clear and concise form. Non-verbal communication. Non-verbal communication, everyone knows na. Some like most of the communication we do non-verbal. Some with the gesture, facial expression. So that should also be maintained with the patient. Open and honest communication. Open and honest communication. Honest means whatever you are telling to the patient, it should be truth. Don't tell anything lies to the patient. And open questions, like it should be not restricted. Sometimes we used to ask, fever is okay. then it is a restricted question because patient will respond to only for the fever. Then question should be like, how are you feeling today? Then patient will tell openly about many things. Today I had this, now I am feeling this, yesterday that happened. So it will be an open type of questions can be there. Culturally sensitive communication. When we are talking with patient and we collect the information, that time we used to know about the patient background. So that time, when we are talking with the patient, we should keep in our mind in patient values, belief, culture. On that basis, we should not hurt the patient on these basis. Then conflict resolution. Conflict resolution, that is family also or between the healthcare workers. So that is when we are talking, if any conflict is there, when we are talking with each other, it could be resolved. So here also communication, a well effective communication skill is needed. 4 principles of communication. These principles can help the nurse to communicate effectively and achieve their goals, whether it is to build a strong relationship, resolve conflict, or achieve success in workplace. First is respect. We should respect each and everyone, to patient, to family, to co-worker, whether it is junior, it is senior, to a student, to teacher, to each and everyone. Because we all had been listened now, when you give respect, you will receive respect. So in nurse-patient relationship also you need to give respect to the patient. It is not like they are paying and we are caring for them. That is not like that. We do have in a noble profession. We should have a like healing hands. We should have a respect, whether they are poor, rich, black, white, male, female, adult, children, whatever, whomever it may be. We need to give respect to each and individual patient. We should approach every patient with like respect, with greetings. Okay, we should always ask the permission from the patient before doing anything. So this is a kind of respect we need to maintain with our patient. Then empathy, already we had been discussed. We should feel the pain of the patient, or we should keep ourselves on the patient place, and there should be a trust. Trust means keeping the secrets of the patient, like don't confidentiality has to be maintained, and if we are giving information, it should be true. It should not like should not be told to the patient. So with this, if the patient came to know you told lie to the patient, then the trust won't be capable of rebuild trust won't be there. Then patient, furthermore, patient won't share anything with you. So the trust has to be maintained with your patient. Next is unconditional positive regard. That means when patient is doing anything, then we know not anytime we need to give negative things. You are doing well, your progress is well. You can, like, we need to motivate positive things. We need to tell, like, you took medicines today, you walked well, you woke up that time, you had this food. Okay, some like yesterday patient was not taking food, but today because you had been talked and everything, then patient had take food. Then you have to give positive regards to the patient, so patient will get motivated with those words. Next, consequences for poor communication. When the poor communication is there, what consequences can face? Like first is increased anxiety and distress. In the patient, anxiety and distress can be increased because something will be there in the patient mind to discuss with you, but patient is not capable of discussing. Sometimes the patient will be it is inside, but we are not capable of telling to the nurses, or we are not capable of asking with them. Then inadequate pain and symptom management, because sometimes we know the pain is subjective data. Until and unless the patient won't tell, we won't be capable of finding how much the level of pain is patient is having. Sometimes the patient will have the capacity to adjust with the pain with a high level, sometimes they won't be having capacity. So if patient is not sharing, not communicating with you, that management we will also lagging behind. Then reduce patient satisfaction. Then if we are not communicating, they won't be feel a healthy environment, they won't be satisfied with the services what we are providing to them. Conflict and disagreement, like patient side, family side disagreements will be there, and they can also say like that hospital nurses was good, they had been told every information nicely. Sometimes they will tell ki, like we were for 2 and 3 hours, they don't allow us to meet our patient. So this type of disagreement can be there. increase burden on the family caregivers, those who are caring for the patient. Like some family member will be there 24 into 7 with the patient now, so their burden will increase because patient is not capable of sharing anything. The last, increase healthcare cost. As long as the patient will be stay in the hospital, the payments and the bills and money will be there now for their treatment stay, so it will also increase the cost of the treatment. Next, frequently use strategies for effective clinical consultation. Response strategy. How we have to respond to the patient. First, it is important to avoid overload of information and medical jargon. Patients should be encouraged to ask questions and attempt is made to address each of them. Here again, checking the patient understanding is an important aspect of the effectiveness of communication. Means, like a lot of information we are having and we are imparting to the patient, like bombarding to them. So we should not get to the patient and tell you are having this you have to do and this medical report you have to bring. Like too much of information we should not give to patient at a time. Then medical terms, that jargons has to be avoided, like simple terms and simple language has to be used. Next, and then in between, we also allow the patient, whether do you understand or not, any doubt is there, any confusions are there, that things has to be asked in between when we are giving any information to the patient. Beginning of consultation, after the greeting and introduction, begin with the open questions. So, how are you feeling today, or what brings you here today, or how you have been doing lately? So, like this, with these questions, we need to start. Such questions are not restrictive and do not pin down the discussion to the pre-decided agenda. This beginning would allow the consultation based on patient agenda and can then proceed with the information sharing and setting priorities. Like this, how we have to start our conversation when patient is coming in outpatient department or after admission inpatient department, how we have to start or how we have to greet with the patient. Closing consultation, here is an important to check patient understanding. Why don't you tell me what you understand so far, or what question do you have? So like this is in between, we need to ask the patient, do you understand, any doubts are there, okay, then what you understand from this, do you need any clarification? So these all things we need to ask in between patient, otherwise patient won't be able to tell. Sometime they will be hesitated or they will be have shy behavior, that time won't be capable of telling. It is also useful to summarize to reinforce joint decision making, that is, I just want to go, or what we have been talking about, this will make sure that we are on the same page. Like we need also collaboration from patient and family when we are going for any treatment, any therapy, any before starting any treatment, doctor used to tell, no, nurses used to inform that this is going to be start and this will be the benefits, this will be the consequences. So we also need their coordination for any treatment and management of the patient. Arranging a follow-up emphasis ongoing therapeutic relationship means there should be a follow-up. It is not like starting, giving some information and ending of the discussion. We should tell, like they can visit to the doctors or the nurses whenever they are needing the information, or there is a gap like 4 to 5 days of gap, they can revisit the hospital. That should be told to them. Response to the emotional cues. Example, I note that you are feeling confused, distressed due to ongoing events, or it seems like this has been very tough for you to cope. Like this, we need to start our questions. It is useful to state it is as normal, understand the circumstances, and praise the patient effort in going through the situation. Example, it is not uncommon to feel this way. Sometimes we used to say, nah, it's okay, it will be okay. Okay, don't worry for that. In that situation, we need to tell like that it is not uncommon to feel this way. You, like if you are having this condition, the symptoms can be there, the feelings can be there, you can, this is common. Or it is natural to feel tired and unable to focus at work. It would be very reasonable to take some leave from work after this cycle of chemotherapy. Like we need to tell, like if you are going through the chemotherapy, this sign and symptom you will have. Sometimes you will feel lethargic, weakness, won't be capable of concentrating on your work. So better to take a 1 day of gap or 1 day of leave. So these things like this, we need to develop our skills to communicate with our patients. Silence. It is very important that silence are allowed through the conversation. This allows the person to gather his or her thoughts through the emotional turmoil and bring out the most significant concern. Continuously, we should not talk with the patient. Okay, sometimes we'll let them think, because we also need, when we'll get something, we also need few seconds to think in our brain. So let them, the patients also think a little, because when they'll get a silence, they will think, they will give a more informative information among for them to you. Response to the patient barrier example. So far we have talked about, there are some more aspects that need consider for us to reach a decision. Would you like to discuss those today? Like before, like patient chemotherapy we need to start, or life threatening condition is there, any therapy we are going to start, then patient, we have given too much of information, we need to discuss with the patient and family. Then we have to say, is it okay to discuss furthermore today, or we need to like postpone to the tomorrow, that further things we can discuss tomorrow. Like this conversation with the patient has to be there. We need to get the agreements of the patient. Examples of good and poor communication skill. Here are the some examples, like what will be considered as a good communication skill and what is considered as a poor communication. So like principles are there. First is ask open question. Open question, you know na, that patient will get a vast area to get explained. How are you feeling today? uh, Two categories are there, poor conversation and good conversation. Open questions for poor conversation will be like, is your pain better today? This is a closed question and restrict and forces the patient to respond. Means we are asking about pain only. The patient is allowed, patient is thinking I am allowed to tell about pain only. Yes, my pain is okay, little bit reduced, no today more. So it is restricted question. Then what it is a correct way or correct communication skill is, how are you feeling? How are you feeling? This is an open question and allows the patient to talk about what is the most important issue of her or him. So this type of communication you should also utilize while you are going to your clinical postings or the community posting area. Next is be empathetic. Example, patient, I feel very scared when I am have a short of breath. This is a subjective data that patient is telling. Then nurse, take these tablets and your breathing will be improved. That is like a poor communication skill. We should provide more information to the patient, like nurse, breathlessness can be very frightening. What sort of fear do you feel when you are breathlessness? Like we need to little divert the patient mind. We need to ask how you are feeling that time, what are other things you are feeling inside. So like this, you can ask like a more information, or we can divert the mind of the patient. Then next is balancing hope and trust. The poor communication skill way will be, there is nothing more we can do. Your disease is incurable and there is no point in continuing and staying in the hospital. Here the doctor is destroying the hope. So sometime you had been seen in the movies, or like they are coming directly and telling your patient is dying. So this is not a way actually. The correct way or good communication will be, I am afraid there is a no more treatment available to cure your disease, but we can definitely keep you comfortable with the regular evaluation and medication we are with you. Like your hospital stay will be there, your symptomatic management will be there, we will be providing the comfort to the patient, medications will be there, but directly we cannot say to the patient ki, like you are having a fourth stage of cancer, there is a no cure, you can take your patient to the home and 2-3 days are left, you can live with them. Like this conversation we should not, you should not have like this conversation. Next is respectful confidentiality and avoiding unhealthy curiosity. Example, patient, I feel distressed by the fact that this cancer is direct consequence of abortion that I had when I was 17 years. I have not disclosed this to anyone. This is a subjective data. Patient is telling, I have got this cancer because when I was 17, I got the abortion and I didn't told any one of my family member or anybody. Then we are not, were you not married then? Then we should not blame the patient that time ki You were not married that time. How you could get abortion? The correct way is, I think we need to discuss this more, as it is obviously a very significant reason for your distress. Be assured that everything that we discuss will be kept confidential. We should also make the patient that your whatever the discussion we are having, it will be confidential, and we need to discuss on this, because directly or indirectly this thing is affecting, and this is the reason or etiology behind your cancer. So we need to discuss, but it should be a confidential information. Next is therapeutic relationship. Example, poor compliance with the medication. In a poor communication, you have not taken the medicine for your pain as I advise. Don't waste my time. Sorry, I cannot see you. Here the doctor is not interested in understanding the reason why the medicines were not taken and correcting them. Doctor asked, or nurse will ask, did you took your medicine? Patient said no. Then you go to home. Furthermore, I will not do any management for, I will not see you, like this. They should not tell, I had given the prescription after due evaluation of your pain. Tell me why you unable to take it. I would like to understand further. Did you have any trouble when you started the tablet? Do you have any question or clarification before using them? Sometimes the patient will have confusion, like what the routine, when they have to take. Sometimes they will get confused. Sometimes we used to write in English, they don't understand. So we need to understand why the patient is not taking. We should not blame, we should not shout. Okay, we should understand. We should again explain to them, again ask why you're not taking the medicines. I feel like everyone is feeling boring, isn't it, students? Sleepy, boring, yawning, no? So there is an ice breaking session. Don't shout. Those who know, they can stand at your place and tell. So here is a question. A farmer is traveling with a bowl, chicken and a bag of grain. Comes to a river they need to cross. The boat only has room for farmer and one. Among one thing can be taken with the farmer in the boat. The farmer cannot leave the wolf alone with the chicken, because he will eat the chicken, and he can't leave the chicken alone with the grain, because the chicken will eat the grain. And how can he get them all across the river safely? Think. Just also can think. Don't discuss in between. You may be knowing it before. Huh?
मैम सबसे पहले हेन को लेकर जाएगा, फिर ग्रेन को लेकर जाएगा, फिर हेन को वापस ले आएगा, फिर वोल्फ को लेकर जाएगा, फिर हेन को वापस ले जाएगा.
It is correct. So this is your answer. The farmer takes first. He brings the wolf second and come back with the chicken. He drop off the other side with the wolf. The farmer makes one last trip to take the chicken back. So now feeling okay, still boring. Okay, so here I am going to discuss one scenario. Like Srimati Sudha, a patient with the acute exacerbation of bronchial asthma, is brought to outpatient by her relative. She is breathless on mild exertion. Hello. And to bed most of the time. So conversation like patient appears worried and tells the doctor, I am scared and not able to sleep. The nurse, don't worry, Srimati Sudha, but I feel anxious. I am awake throughout the night. I am not capable of sleeping. The nurse, I know I shall give you medicine to get good sleep. You will be all right. The physician, hello, the post-op OPD declining not to take the prescribed medicine. This was the communication. Means like patient came to OPD and she was telling I am having sleeplessness. Then a doctor told to give the medication. You will be okay. Then patient said I will not take the medicine, and they leave the OPD. See how to handle them differently. How we need to handle the patient differently. Here, Srimati Sudha appear really apprehensive and is not able to sleep. The physician prescribed anxiolytics so as to make her sleep. He has not taken a detailed history to explore the reason behind her apprehension. It is because she had a relative who died from breathlessness. Means, what conversation you had seen, patient came and doctor just prescribe the medicine to take, you will get the sleep. But the correct way is, first we need to collect a proper history. Why? When we will collect the history, there will be some reason why the patient is having sleeplessness. The reason is some of her relatives had been died because they were having breathlessness. It is worried that how longer her illness would continue. Is she upset because she continued to be burden to her family? She is thinking, I am having this condition every time my relatives and family are taking me to the hospital. This is burden to them. Some of us will think like that. No, some patient will think. So eclectic and addressing these are the most important aspect of creating her insomnia. Prescribing anxiolytic without exploring her concern would shut the door for self-expression and definitely will not settle her symptoms. So before prescription, that's why we used to tell don't take over the counter medication. Use go and consult your doctor, physician. They should ask you from when you are having fever, what other things are there. Like that also we need to ask the patient. The full history has to be taken. As a nurse, we have the first priority to collect a history of a patient. Our teachers and everyone will tell them whenever you go to hospital, first and foremost work is when you are doing to go, what you have to do, you have to collect the history of the patient. Learning to communicate with the patient with advanced and progressive disease. Like patient, a 25-year-old Geeta has came to meet the doctor. She has been diagnosed have advanced cancer of stomach. She has not been eaten much for last 5 days. She has not been interacting with her family and has been mostly confined to her room. She has even stopped telling stories. One of her favorite pastime to her little niece, whom she is very close. Means this is a patient scenario. One patient was there. This is Geeta, 25-year-old, and she is having an advanced stage of stomach cancer. In many things, what she had been stopped, like her favorite time pass was her small little niece was there, and she used to tell the story. That work also she stopped. She is not talking to anyone. She is not visiting to anyone like she wishes to speak to doctor alone and say chemotherapy is not helping me. I cannot stand it. Doctor, please stop. Please help me. I want to die. Okay. These are the things which she is not capable of telling in front of the family. So in alone, she want to meet the doctor. Then this is a statement how the doctor will respond to the patient. Do you think one of the following responses would be appropriate? Like, you should not say such thing. God gave you life, trust him. You must chant regularly for the strength to endure this. Chants like our prayers or anything for the patient we can do. Then look at that man over there. He has no family. He is alone and in pain. At least be thankful that you are having a lovely family. This point is comparison. Before we should have been studied and seen that we should not do any type of comparison with the patient. Next, oh, you poor things. It is so sad you have to go through this terrible disease. There is nothing to be afraid of. Be brave. We shall look after you. Don't worry. It is a famous cell carcinoma. It is quite radiosensitive. You have a good chance of remission. Oh, so you are waiting for your final visa. Like when your general health improve, we shall try more chemotherapy. Like this question, do you think these are useful? Like these things we can tell like patient like this. So here's something, do not immediately reply to the patient. Like we can take that same Geeta patient, Geeta's statement, it may be more appropriate to respond with another question. I can see that you are already deeply distressed. Would you like to share your thoughts with me? That conversation could be like that. Do not philosophize or moralize the patient. You should not say such thing. God give you life, trust the God. They may hurt the patient feeling conversation. So next, avoid comparison with the patient. As we had seen in that example, avoid meaningless words in front of the patient. Next, avoid medical words, that medical jargons. Avoid false reassurance when the patient condition is worse and you are telling no, everything is okay. These all things has to be avoided in front of the patient when we are communicating with the patient. Do not make assumptions without any rationale. Avoid patronizing attitude. Patronizing, like the patient will open up to you only if you deal with him or her with a respect. We cannot over command the patient. We cannot force the patient to respond, to communicate, to give the information. Do not force your beliefs or convictions. Do not your religious things don't give to the patient, or don't let them behave in your way or on your religious or cultural way. Avoid sympathy, convey empathy. That we had been discussed in many times. What is sympathy and what is empathy? How we have to behave. Avoid inappropriate humor. Inappropriate humor, like in the last example we had been seeing, like your final visa had been came. So these all things, the things need to be avoided during the conversation. Avoid both lies and thoughtless honesty. We should be transparent. What is truth is there, that only things we have to tell. So here one supportive study is there, research study, a non-experimental design study was conducted by Charlie Moyer, Rennie Robert et al. At St. Luke Health System, Bangkok, Boys, USA, on communicating with the patient and their families about palliative and life, end of life, comfort and educational needs of staff nurses. In that study, it was utilized 16 patient nurses completed the end of life professional caregiver survey. It was published in year 2015 March. A study revealed that nurses with the less experience in terms of year and patient population, means those nurses who are having less clinical experience and they had been, like sometimes they work in the small hospital, the number of patient population is very less, demonstrated a moderate level of perceived skill in the end of life care, but exhibited a significant need for additional knowledge. Those who have worked with a less population and having less year of experience, they are needed much knowledge on communication skill, and they need to develop a more communication skill. Further research is necessary to determine for effective educational strategies to address this knowledge gap. The study included that targeted education for less experienced nurse can enhance comfort level and improve care of end of life patient, while experienced nurse demonstrated higher skill level in addressing the palliative care needs, highlighting the importance of ongoing education and training. Means this study main focuses on the nurses. They had been selected the nurses and seen those who are more experienced and dealt with the more population of patients, and the who are less experienced and dealt with the less population of patients. How they are, what are their communication skills? How they are representing with the patient? How what type they are using the technique? So this research was on that. Steps for effective communication. Before communication, first of all, that is build a relationship. A proper nurse patient relationship has to be maintained. Then open the discussion and gather the information, starting the discussion, and whatever the genuine information is there, we need to gather. Then understand the patient perspective. First, like we need to listen to the patient properly and share the information, reach agreement, no problem, and plans. Like what we are going to plan, those things has to be shared with the patient. And at the last, the conversation has to be closed, the discussion has to be closed. These are the steps for the communication process. Communicating bad news. When the news is really bad, like disclosure of diagnosis of cancer, however well communicated, bad news is still bad. It is important to understand how the patient may be responded to the bad news. how the patient may respond to the bad news. The aim is to minimize the impact, to remove the needless fear, to instill the realistic hope and make the person cared for. Means the bad news, how nicely we are giving, it will be bad only. It will be like emotional distress for the patient, but we need to like have some improvement in way of our communicating bad news to the family and patient. So Elizabeth Kubler-Ross has described the different possible reaction to a bad situation, that is denial. The patient won't accept it at all. No, this can't happen to me. Anger. The patient will show that these stages already all of you know now in psychology. Studied know those 5 stages, so I will not go in much detail about this. Like this is the response process, how the patient will respond. Denial, the patient will not accept it. Anger, the patient will respond with the anger. And bargaining, the patient will have substitutes because of this is happening like this. Next is acceptance, the patient will accept the condition, accept the situation. And the last stage is, that is depression. Depression means the patient, because of that condition, the patient will have some psychological effect. The Spikes protocol, a 6-step process first described by the Buckman and Bailey, is often used to help the healthcare worker communicate bad news with sensitivity. These steps are as follow. First is setting. Like we got the information, any place we are standing, and we should not impart. We should take a calm place, quiet environment. Then we should give the, so setting is very important for giving any information or bad news imparting to the patient. Then perception, like we need to discuss with the patient and then we need to disclose the information. Invitation, knowledge, emotion, strategy and summary. Like we given the information, we should not walk out from there. We should explain the things, we can tell the further management and treatment, and we should take a patient decision also, what they want to do, what family want to do. So this process fully has to be followed, not like 2 steps had been followed, another step had been left behind. So full process has to be followed. Breaking. So here one other supportive research study is there. The study had been done by Ruth Parry in 2020-24, conducted a research study on communication in palliative care and about the end of life. A state-of-the-art literature review of conversation analytic research in healthcare, research on language and social interaction at Center of Research in Communication and Culture, School of Social Science and Humanities, Loughborough University of UK, and the study had been published online 3rd April 2024. 22 publications were included in this study. Uh, their key theme were initiating and managing the topic of dying, of progression and of advanced care planning, and interactionally managing the emotions. The study included in this review are not about death and dying in the abstract. They analyze interaction about dying in very specific sensitive context when an healthcare practitioner, a patient, and sometimes a companion refer or attempt to refer to the fact that patient is going to die. Like it is this study was mainly based on the interaction, the patient, healthcare professional and the nurse and the family, when they do have the interaction, on that basis the study had been conducted, and the research had been, the result, the concluded that healthcare interaction about the end of life, dying and the death could contribute to the deepening sociological and social psychology understanding of fundamental matters, including how we construct the meaning of life and dying for ourselves and others, how healthcare differ when we aimed at cure, and when spiritual and existential matter forms part of agenda, and this research paves path for further discussion and research. Because dying, when we are talking, we could not say na patient is dying, that is end of life, we don't have to do anything. Time should also be peaceful, comfortable, happy. That last time also we should need to cure the patient, like we are caring the patient when the patient is having less illness, less complaints. Like that, we should not tell like the patient is going to die. We don't have to do much for the patient. So this study was based on that. And next topic is collusion. Collusion is please don't tell. Like hiding the information. That is known as collusion. The act of shielding information from the patient or family is called collusion. In palliative care, collusion refers to the situation where healthcare provider and the patient or family member avoid discussing the difficult topic such as end of life, decisions, progression, or treatment option. Because it is a difficult situation, no one can discuss those things. So sometimes there will be a hiding. Sometimes we'll tell our mother is heart patient, don't tell to her about my condition, my failure, my result. Like this situations will be there. So that is known as collusion. Here we'll see types of collusion. There are three types of collusion. First is family collusion, provider collusion, and last is patient collusion. Family collusion, when family is hiding the, like family and doctor will have information and they are hiding the any information about their health from the patient. Like the conversation and information sharing is between the healthcare provider and the family members. That type of collusion is known as family collusion. Second is provider collusion. Provider collusion means when the healthcare professional, those who are providing care, they are hiding the information from the patient and family. Last is patient collusion. When patient is not informing what they are feeling, what, like some things will be there, some backgrounds will be there, some conditions will be there. They are not sharing with the healthcare professional as well as to the family member. That type of collusion is known as patient collusion. Effects of collusion in the palliative care, like lack of informed decision making, loss of trust, increased emotional distress can be there, worsened quality of life, and legal ethical implications can be there. Like if the doctors or the nurses are not informing with the families, not giving the proper information, it is illegal thing, because as a family members, as a bystander, as a patient, we do have the right to get a proper and correct information. So, good communication is a skill that ensures improvement. Good communication is essential for ensuring the patient need and under allowed, and it can be met by healthcare team. Good communication allows the nurses to connect with the patient and those who are important to them, understand their priority and wishes, and support them to make informed decision about their care. So, in today's session, we had thus, so far we had been seen that about the definition of palliative care, and we had been discussed regarding what are the communication skill, why it is important. If we fail, what will be happen? Why we about how we have to communicate with the patient, and we also had been seen collusion. We see some scenarios. We see research studies. We had been seen. So this was all about my today's session. Hope it was not boring and it was a little knowledgeable for you all. And thank you for listening actively and not disturbing the session in between. And thank you, teachers, for your time.
Thank you, Ms. Divya Pandey, for that insightful presentation. You have certainly set the stage for understanding the core principles of communication in palliative care and why it is indispensable in improving the quality of life for the patient. Moving further, our next speaker, Ms. Harshita Tripathi, student of MSc Nursing second year, will address pain assessment for critically ill patient. Please join me in welcoming Ms. Harshita Tripathi.
Morning to everyone. I I'm Harshita Tripathi, student of MSc Nursing second year. I'm here to present my topic on assessment of pain for critically ill patients. Hope this session will help you for the future. I will start my topic with these thoughts. The body, the body does not give up on us, so we can't give up on it. It was said by Paula Abdul. Pain is not just a sense or information appraisal, but an emotional experience. First definition. Everyone has experienced some type or degree of pain. It is the most common reason why people seek health care. Despite being one of the most common occurring symptoms in the medical world, pain is one of the least understood. A person in pain feels distress or suffering and seeks relief. However, the nurse cannot see or feel the client's pain. Pain is subjective. Now, pain is considered to be a separate disease. Like we have seen that pain is subjective, so no one can understand or feel that sensation. Only the person can describe what is the feeling and what his or her body is feeling during that pain. So uh, pain signals your nervous system that something may be wrong. It is an unpleasant feeling such as prick, tingle, sting, burn, or ache. Pain may be sharp or dull. It may come and go, or it may be constant. So pain is a subjective feeling, as we know, and it can be uh, we can feel the pain with the different characteristics, like it can be as a prick, tingle, sting, or burn, and it can be sharp or it can be dull. So according to that, we can describe what is the intensity, what are the characteristics, and what is the nature of pain. So now we will move towards the definition. Pain is the sensory experience evoked by stimuli that injure or threaten to destroy tissues, defined introspectively by every man as that which hurts, by Mont Castle. Pain is a sensory experience that is evoked by stimuli. There will be always a stimuli behind the pain, and uh, for the person to person, it can be vary. That was said by Mont Castle. An unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage by International Association for the Study of Pain. International Association for the Study of Pain said that it is an unpleasant sensory response that can be due to actual or potential tissue damage. Like the stimuli of that pain can be actual or potential tissue damage. According to American Pain Society 2003, refers to as the fifth vital sign. Now, nowadays we are assessing the pain with the vitals. When patient come, we take history and we, with the vital signs, we ask that you are having any pain, or as a fifth vital sign, we assess the pain. The American Pain Society also stresses the importance of self-reporting. Pain is always subjective and the clinician must accept the patient's report of pain. As we know, uh, we have listened that also that pain is subjective or individualized. So we should give importance to the self-reporting of the patient. Like patient will describe how he is feeling, how the pain is feeling now, like sting, burn, ache, whatever his. So now we will move towards nature of pain. Pain is subjective and highly individualized. Pain can be vary person to person, so person can only describe what is the feeling of pain. It is a stimulus that is both physical or mental in nature. Pain can be physical or it can be also mental.
Like physiological stimuli can also activate the pain sensory responses, and mental conditions can be also cause pain. It interferes with personal relationships and influences the meaning of life. When a person gets pain, he will get anger, he will get irritation. So it can affect their personal relationships also and influence the meaning of life also. Like why me? Why only me? I am the getting pain. Only the patient knows whether pain is present and how the experience feels. Patient will only know what is the intensity of pain. According to that, he can share his experience. May not be directly proportional the amount of tissue injury. Sometimes pain is idiopathic, like it cannot be due to any stimuli. Sometimes emotional or psychological reason can be behind the pain. Now we will move towards sign and symptoms of the pain. Uh, we can see all these sign and symptoms when a patient or a person is having pain. Increased respiratory rate, increased heart rate, peripheral vessel constrictions, pallor, elevated blood pressure, increased blood glucose, level of diaphoresis, dilated pupils. Mainly these symptoms can be shown when our sympathetic nervous system is activating, because it gives response to flight and fight conditions. So we will get all these symptoms while a person is pain. Patient response to pain. We can see these responses of the person when he is having pain. Sobbing can be there, guarding the area, like person will protect or he will not move that area. When we are having pain in our knees or any area, we will not move that part more. And after that, restlessness will be there. Irritability, a person can get irritability when he is having pain. Here we are having types of pain. First, cutaneous pain. This is caused by stimulating the cutaneous nerve endings in the skin, resulting a well-organized burning or prickling sensation. For example, tangled hair, pain cuts, minor burns, and lacerations. Cutaneous pains, like our cutaneous, in our body full of cutaneous nerve endings, so it is attached with the skin. When any stimuli that is provoking pain, then we will feel the prickling or burning sensation, which can be tangled hair, paper cuts will be there, minor cuts are there, so we will feel the cutaneous pain. Somatic or deep pain. This is non-localized and originates in supporting structures such as tendons, ligaments, and nerves. Deep pain is poorly localized, may produce nausea, and it is frequently associated with sweating and change in blood pressure. Deep somatic pain is generally diffuse and less localized than cutaneous pain. Also, pain from deep structures frequently radiate from primary sites, like pain from the lumbar disc to pain felt along the sciatic nerve. Like if we are talking about somatic or deep pain, it can be originate from these structures like tendons, ligaments, or nerve. When we are getting any injury which is related to ligaments and nerves or tendons, and this pain is poorly localized, like person cannot say that it is here I am feeling the pain, like it is bone pain or related to any nerve or any nerve is stretching. So, and we can see some changes like sweating and changes in blood pressure, like all the sign and symptoms we have discussed before. That sign and symptoms we can see in the person. And this pain is generally diffuse or less localized than the cutaneous pain. Like cutaneous pain, we can see exact reason where the lacerations the person will get. He can say, here I am getting the pain. But with deep pain, we cannot say that here I am getting the pain. Visceral or splanchnic pain. Visceral or splanchnic pain. Visceral pain is discomfort in the internal organs that is less localized and more slowly transmitted than cutaneous pain, and usually accompanies autonomic manifestations. Visceral pain is transmitted through Sympathetic and parasympathetic fibers, that ANS, with the pain often refer to the body surface, often the distant sides. Mainly visceral or splanchnic pain we will get when our internal organs or smooth muscles will get contractions, and these contractions which can be caused by autonomic nervous system. Based on the duration, pain is divided into two, which is acute pain and chronic pain. First is acute pain. Acute pain has a sudden onset, relatively short duration, mild to severe intensity, and a steady decrease in intensity over days to weeks. Once the noxious stimuli are resolved, the pain usually disappears. It is used mainly acute pain is that it can be occur sudden, and when any noxious stimuli like any harmful or any stimuli behind that, we will get acute pain. It is for certain times, for short duration we will feel pain, and after the stimuli will resolve, the pain will also disappear. Recurrent acute pain, it is repetitive painful episodes that reoccurs over a prolonged period or throughout the client's lifetime. Pain intervals alternate with painful episodes. Recurrent acute pain, we can say that repetitive episodes person will get pain like headache can be, or a person who is having migraine, he will have lifetime pain he will have, and that will onset with the episodes. Next is chronic pain. Chronic pain is defined as long-term, persistent, near constant or recurrent pain producing significant changes in the client's life. Chronic pain may last long after the pathology is resolved. Chronic pain can be defined as long, it can be the for long time, it can be persistent, and after the resolving of the noxious stimuli, it can be present there. Like can feel rheumatoid arthritis pain, osteoporosis are the examples of these pain. Chronic acute pain, it occurs mostly daily over a long period, month or years, and may never stop. For the example, cancer pain. Chronic non-malignant pain, it is also called chronic benign pain, occurs almost daily and lasts at least for 6 months, ranging from mild to severe intensity. Three critical characteristics of the chronic non-malignant pain are identified by McCaffrey and Pesero. Non-malignant pain, it can be almost daily, basis, and it can last more than up to 6 months. And here are the three characteristics of the non-malignant pain caused by non-life threatening cause. Like what is the stimuli behind the chronic non-malignant pain? It will be non-life threatening, like rheumatoid arthritis, fibromyalgia pain. These are the pains which we feel lifetime, but it is not that much life threatening. Non-responding to currently available pain relief methods, like what we do for the resolving the pain, that methods will not work on that person or that particular patient. They continue for the rest of the client's life, for the example rheumatoid arthritis, and it will last for the rest of life for the patient. Next, pain based on the intensity. So as we all know, mild, moderate and severe pain we can see in when we are talking about intensity. So mild pain, when pain is still reading from 1 to 3, it is considered as mild pain. We are having pain scale. So according to a numerical pain scale is there, and a categorical pain scale is there. So in that scales, when pain ratio is pain reading is 1 to 3, then we will consider it as a mild pain. Next one is moderate pain. When pain is a scale reading from 4 to 6, it is considered as moderate pain. when we will have a reading of pain from 4 to 6 on the pain rating scale, we will consider it as a moderate pain. Next one is severe pain. When pain is a scaled reading from 7 to 10, it is considered as severe pain. So here are the some other classifications of the pain. First, psychogenic pain. Psychogenic pain can be due to emotional outburst or from the stresses conditions. We know that sometimes stimuli behind the pain is can be psychological. Idiopathic pain, there will be no any stimuli but pain will be there, so that is known as idiopathic pain. Nociceptive pain, nociceptive pain is can be called as we can know that pain when any harmful stimuli behind that pain, that is known as nociceptive pain. Neuropathic pain, differentiation uh, differentiation pain. Next is purposes of pain. What is the purpose behind the pain? Severe as a protective mechanism. As we know, pain is a fifth vital sign, and when anyone is getting pain, he will go for the consultation or he will seek medical help. So pain can serve as a protective mechanism. And next one can be a diagnostic tool. Like we can diagnose any disease based on the sign and symptoms. Like anyone is having joint pain for the long time of period, then we can go for the further diagnostic evaluations for the rheumatoid arthritis and like that. Next one is physiology of the pain. The opioid system and non-opioid system are two known endogenous analgesia systems in human. The best known is the opioid system. It is mediated by endorphins. The non-opioid systems is mediated by monoamine substances such as norepinephrine and serotonin. Usually these are two systems which is present in human body which respond for the pain, mainly endorphins, and there are some monoamine substances like we all know it as a neurotransmitters which can be can give us the sensation of the pain. Dimensions of pain and pain processes. Here we will see some dimensions because pain is a multi-dimensional phenomena. So physiologic, behavioral, sensory, cognitive, and affective dimensions will be there for the pain. So first here we will see physiologic dimension of the pain. First, transduction will be there. If any mechanical, thermal, or first we will see transduction. If any mechanical, thermal, or chemical stimuli into a neuronal actions potential stimulus. Mainly the stimuli is behind the pain transduction, and after that transmission of pain, like movement of the impulses, and it will go towards the spinal cord, and from that nerve bundles will go to brain, and it will activate the pain centers. So we will do so that pain centers mainly transmit the pain, and after that perception, pain is recognized, defined, and responded by the individual. And after that, modulation. Modulation means it changing in the intensity of the pain. Like in human body, there is modulatory pain system is there, and with the modulatory pain system, it activates the opiate system, which usually changes the intensity of the pain.
Okay. So I think everyone is feeling bored, so we will move towards the ice breaking session. I think you are liking ice breaking sessions between the seminar. So here is one joke. पिता पेपर कैसा गया? बेटा पहला सवाल छूट गया, तीसरा आता नहीं था, चौथा करना भूल गया और पांचवा नजर नहीं आया. फिर फादर इज आस्किंग, और सवाल दो बेटा, बस वो ही सवाल गलत हो गया, नहीं तो बाकी पेपर में अच्छा देख के आया. Okay, so next one is here. It is dedicated to our all teachers. A lady police is there. A lady broke the traffic signal. So police, stop. Lady, please let me go. I am a teacher. Police, aha, I have been waiting for this moment all my life. Now, right, I will never break a signal 100 times. Next one for our BSc 4th semester students. टीचर, सेमेस्टर सिस्टम से क्या फायदा है बताओ. पप्पू, फायदा तो कुछ नहीं है, पर साल में बेइज्जती 2 बार हो जाती है. Okay, so now we will move towards our topic. Here is sensory, affective, behavioral, cognitive, and socio-cultural dimensions of the pain. Sensory, like what person is feeling, element included pain, area, intensity, and nature. The affective component, like what is the response of the person he is giving after he is getting the pain. It can be anger, fear, depression, and anxiety, or negative emotions can be also there. And next is behavioral components. Behavioral components like that, how the person is behaving, or how he is, when he is feeling or he is getting stimuli, like grimacing the or he can squeeze his face, stretching his face muscles. And socio-cultural dimensions of pain encompasses factors such as demographics, like age, gender, and education. Theories, here are some theories behind the pain. First is specificity theory behind theory of pain. It was developed by Max von Frey in 1895. The concept of this theory was each sensory modality such as touch or pain is processed through separate pathways in the nervous system. Touch and pain stimuli are detected by specialized sensory organs. The nerve impulses for each modality travels along distinct pathway that ultimately project to their respective centers in the brain responsible for processing touch or pain. According to the specificity theory, we can this theory shows mainly the pain what we get, it is due to nervous system, or our nervous system is having different pathway and it trigger the pain center, so we will get the perception of the pain. This theory suggests the pain is perceived after the injury through a detective dedicated system of afferent nerves, that these nerves carry signals from specific pain receptors in our body, the brain pain centers. It purposes that certain nerve ending respond to the non-receptive stimuli, transmitting information to specialized area, the spinal cord, which then relate to the thalamus and relevant sensory cortex. Our afferent nerve, which admitted the pain, and it mainly it activate the brain's pain centers, and after that nerve ending responded, so we will feel the pain. Here are some images. Through these we can mainly receptors, a bundle of receptors present in human body. So receptors will trigger out the spinal cord, and through the spinal cord nerve bundles will go to the higher centers of the brain, which is medulla, thalamus, and cortex. So with the help of neurons, we will get the sensation of the pain. Like in one pattern, like we will getting a stimuli, and after that afferent nerve will activate the bundle of neurons which is present in spinal cord, and after that it will spinal cord will send the impulses to our brain, and it will trigger the higher centers, and we will get the perception of pain. Pattern theory. Next one, theory of pain is pattern theory. The nerve involved in the detecting pain also detects other sensations relates to the perception of pain to the pattern of impulses in the nervous system. Rather than to impulses in dedicated pain pathway, the pain pathway may be temporal or spatial. Pattern theory may explain some chronic or recurrent pain that occur when there are nerve lesions. Mainly pattern theory said that we will get pain in one pattern through the what are the systems pathway are involved in the nervous system through these pathways, and with the bundle of neurons we will get the sensation of the pain. Next one is gate control theory. Here alpha and C fibers are there, and here Pacinian capsules are there. A and C mainly A and C fibers are there which will respond to the painful stimulus, and so when we are getting painful stimulus or deep touch, these fibers or capsule will activate, and with the DCML is dorsal column medial laminis, and with the primary neurons it will trigger the spinal cord, and secondary neurons will go to the send the with the secondary neurons impulses goes to the brain, and with the help of the tertiary neuron the again impulses came back from the help of efferent nerve, and here substantia gallantiosa will work as a gate, like it will receive the impulses and it will transfer the impulses. Next, factors affecting pain experience. First is age. Age can be age can affect the tolerance level of the pain. Previous pain experience. Pain experience, like person will be ready. If he is getting the pain in the form of episodes. Drug abuse. It can reduce or increase the sensation of the pain. Next one is cultural norms. Gerontological consideration. Gerontological consideration are like when a person is getting aging or he is getting older, the pain sensation can be differ from the adult person. Next one, phase of the pain experience, the anticipation or fear of the pain. Before a person is getting pain, he will have some sign and symptoms like sweating or irritability. So he will have some anticipation like a prior feeling. Next one is the sensation of pain. When after the anticipation or fear of the pain, when the our nervous system will work, the person will have sensation of pain, and aftermath of pain. Aftermath is like after the pain intensity, may the intensity can be decreases or it can be elevated. Next one, assessment of severity of pain. So here are some mnemonics are there. So in these patterns, we can assess the pain. So always listen carefully to the patient regarding his or her pain. As we know, pain is subjective, individualized. So always we will prefer the self-reporting of the patient, and the details of the pain assessment can be memorized by using the mnemonic PQRST. Uh, P like precipitating or elevating factors. Q quality of the pain. Quality of the pain like what in which manner he is getting pain, prickling, burning, what is the sensation of the pain. Next, reason and radiation of the pain. What is the location, exact location of the pain, and radiation like it is going from one part to another part. Next one, severity. In we can severity only the person can tell the severity of the pain like he's getting mild, moderate or severe pain, and after that timing when it is started and from how much long period it is happening. Next one, old card method of the assessment. So here are the mnemonics from the O, onset of the pain, when it was started, location, uh, what is the reason of the pain, duration, from how long, and characteristics like same thing, burning, prickling sensation, and after that elevating and aggravating factors like if he is moving his hand, so it is uh, getting more severe. And next one is radiating or elevating factors. What are the factors which is increasing his pain, timing and severity of the pain. Next one is cold spa system analysis mnemonic. Here, characters like describe the sign and symptoms, what he is feeling. And next one is onset, when it was begin, location, where it is, like which of the body part he is getting the pain, duration, how does it last. Next one is severity. As we know, there are some categorical and numerical scale for the pain assessment, so we can assess the pain severity. Next one, pattern. What is making it better or maybe worse? It can be any position can be there, which in which position he is keeping that extremity that can feel makes him better, or any movement is there what is getting through which pain is getting worse. Next one is associated factors, like what other symptoms is occurring. Like here you can see headache, vomiting, diaphoresis will be there, elevated pulse rate will be there, elevated heart rate will be there. Next, available pain scales for assessing the pain. So here we will study about some pain scales. This may be done using mainly we use various pain scales, but a few pain scales I have included in my topic. Categorical pain scale. The patient is asked to grade his pain as having no pain, mild pain, moderate, or severe pain as or excruciating pain. Like there are the some numbers, and we all have seen that type of pain. Like if pain is scaled as 1 to 3, it will be considered as mild. When pain is having a score of 4 to 6, it will consider as moderate. And if pain is having scored between the 7 to 10, it will consider as severe. Next one is numerical rating scale. So in patient can give the numbers according to his severity of the pain. So we can ask the patient. These pain scales are only effective if patient is not having any mental issues, because then only the person can give the like category or numbers to his pain level. Next one is visual analog scale. It was firstly used by Hayes and Patterson in 1921. The visual analog scale is shown to the person who is asked to mark the pain according to its severity, then assess the grades of the pain from pain on the 0 to 10, which is even on the reverse side. Mainly, here are some facial expressions. According to that, person will grade his pain, and here are some numbers are also there. According to the pain severity, the person can give the response towards this scale.
And here are some criteria how we will differentiate between the mild, moderate and severe pain according to patient rating. Pain scale, as we all studied before. So again, I need to discuss it. If pain scale is 0 to 3, it will consider as mild, 4 to 7, moderate, and 8 to 10, severe. Here is one related research regarding pain scales. So mainly it was conducted by Barbara Hogarth. They have taken 3 pain scales like visual analog scale, verbal rating scale, and numerical rating scale. They have taken data from the articles and they have seen if they have reviewed the effectivity of these pain scales. Like they have seen that numerical rating scale has good sensitivity and generates data, and visual analog scale is having some practical difficulties. Like it is unidimensional scale. We cannot cover all the dimensions by using the visual analog scale. By this research, we can get this conclusion. And according to me, also the visual analog scale is also is a unidimensional. So we have to assess the pain by focusing on every dimension of the pain. Next one is Wong-Becker-Facius pain scale. It is also called as non-verbal scale. The Wong-Becker-Facius pain rating scale is a tool that uses a combination of faces, numbers, and words to help a person effectively communicate the severity of their physical pain. Like person can respond towards this scale by his intensity of the pain. Like here are some faces and words are also there and some numericals are there. So according to his pain intensity, characteristic, nature, he can give the uh, rating to this scale. Next one is behavioral pain scale. Mainly these scales are using for the non-communicative patients. It can be related to any age group. The behavioral pain scale is a validated observational tool to assess the pain in patients who are sedated or mechanically ventilated. So here in this pain scale, we will have some parameters. So according to these parameters and findings, we can uh, find the mild, moderate, and severe pain. Like facial expression, if patient is having positive expression, then we can give 0. Like he is having no pain, then he will give no any expression. Neutral expression, like if then we will give 1. Slightly negative expressions like grimace, then it will consider at 2. If definite negative expressions like forehead, brow, eyes closed tightly, then he maybe he can have pain. So we will give number 8. Cry. Uh, Next parameter is cry, laughing or giggling. If a person is laughing, that definitely he is not having any pain. So we will consider it 0. Not crying, but he is having pain, but it is tolerable. So we will consider it 1. Moaning, quiet vocalizing, gentle or whimpering cry, like softly he is crying. That degree of if pain he is having, so we will give him or her to full launch cry or sobbing. If a person is crying, so we will give 3. Or full lunge cry more than baseline cry, like he is not softly cry with the voice, high voice he is crying, so we will consider it 4. Next one is movements, usual movements, activity or resting, relax. If a person is relaxed or then he is having definitely having no pain, then we will consider it 0. Partial movements or attempt to avoid pain by withdrawing the limb with puncture is where puncture is done. Mainly fisting can be there, stretching the limbs. So person he will think that if I am doing these things, then I will not get the pain. So we will consider it 2. Agitation with complex movement involving the head, torso, and other limbs, or rigidity. Like he is rigidly he is showing movements, then we will consider it 2. And according to that severity, we will rate the. Next one is Wilda scale. Wilda scale like from the W is W we know as words, intensity of the pain, location of the pain, duration of the pain, and aggravating or elevating factors of the pain. Words like self-reporting of the pain by the patient if it is there. Next one is intensity, like mild, moderate, severe intensity getting. Location of the pain, what is the exact location of the pain. Duration, when it started and still it is there or not. Next one, aggravating or elevating factors. What are the factors? Like if he is getting cold temperature, it is elevating the pain, or calm, or maybe he is moving his hand, so he is getting pain. Factors will be. Next one is simple descriptive pain intensity scale. A simple descriptive pain intensity scale is a set of words that describe pain levels such as no pain, mild, moderate, severe, very severe, and unbearable. Sometimes picture are also accompanied with the words. There can be, we can show the patient some facial expressions can be there, which the patient can say that this intensity pain I am getting. So here are verbal pain intensity scale. Next, related reviews for your discussion. Mainly, this review was explored by the Deborah McGill and Karen Snow, Mary Ellen Hayfield. Many of the person was involved in this research. It was conducted in 2017. And to understand the feature of these tools, they have done this research. They have taken at least 3 case studies. They have taken from the different it was done by the for the non-communicable adults for the giving them palliative care, and they have taken data from at least 13 articles which have given that behavioral pain can be suitable for the non-communicable patients, and we have to do further more studies to get effectiveness in pain assessment tools. So here I will summarize my topic as we discussed in today's session, like introduction of pain, definition of pain, nature of pain, sign and symptoms we discussed, and pain response to the patient response to the pain, types of pain also we discussed, physiology, theory of pain, methods of pain assessment, and scales of pain assessment we also discussed. So here is my conclusion. Uh, as we know, pain is beloved enemy. Like if it is not there, we could not seek for the medical help, and we can consider the pain as a fifth vital sign also. And if we are not managing the pain properly, it will get worse. Thank you for listening.
Thank you, Ms. Harshita Tripathi, for shedding light on the collaborative efforts involved in the palliative care. It's clear that when healthcare professionals from different disciplines come, their care provided becomes much more holistic. Next, we are honored to have Ms. Priyanka, student of MSc Nursing first year, who will develop the pain management for critically ill patient during the palliative care journey. So I request Ms. Priyanka to come on the stage.
Good afternoon, respected principal sir, vice principal ma'am, and principal of paramedical sciences of Sultanpur, and all teachers and professor and dear students. Today, good afternoon. Today we are going to seminar. Seminar. My seminar topic is pain management and critically ill patient. Firstly, we are discuss about introduction of pain. Introduction. American Pain Society 2023 refers pain as the fifth vital signs. American Society says that 2003 pain is a fifth vital sign. All are know, I think. Next point, pain is a multi-dimension phenomena. It means pain is multi, different area like physical and mental and social pain occurs. Next point, it is a personal experience with no objective measurement. Pain is a subjective data, all are know. Pain is a subjective data, not evaluation, not manifestation, only inter experience and pain feel experience. Next point, pain is a best vibe as an experience, not merely as a manifestation. Pain is a vibe, pain is a vibe and experience. Pain is experience and feel, not a manifestation. Next, next, next point. The stress response to critically illness can have many deleterious effects. If any person having pain, person take a more stress, that will lead to dangerous effect of the person effective, more harmonious effective. Next point, appropriate use of sedation and analgesic can attenuate the stress response, alleviate pain and anxiety, and improve complication with care. If I'm using analgesic and sedation, will reduce the anxiety and pain and confusion. Next point, and improve the health care and complication, reduce complication. Next point, agitation response best to anxiolytic drug. Pain is a best relief by analgesic. If person having agitation, give an anxiolytic drug, relief and agitation. And if patient having pain, give analgesic drug, reduce the pain. Understand? Next point, like body part pain in different pain, like back and hand and headache and foot and chest, different body part pain. Definition. Next we will discuss about definition. Already Asita ma'am told this definition. I think no need to explain about. I will explain what is pain. Pain is a physically disturbance caused by illness, injury, damaged tissue. It leads to, if any person having cut and injury damage, then you feel na pain. Without cut, without injury, not feel pain na. It is called pain. Understand? Pain in ICU. First point, post-operative wound and incision discomfort. After surgery, any wound occurs, any wound and this incisional discomfort. Incisional, it means any incision, patient getting pain. Next point, trauma including soft tissue injury, burn, bone fracture. All are no trauma including soft tissue. Trauma, any patient having trauma, soft tissue injury and burn, bone fracture will lead to pain. Next point, acute myocardial ischemia and myocarditis. All are studying in MSN. What is acute myocardial ischemia? Acute myocardial ischemia, also known as cardiac ischemia. When cardiac muscle not get enough oxygen, nutrition due to blood flow, it is called myocardial ischemia. And myocarditis, myocarditic infection and inflammation of middle layer of heart. It's called myocarditis. Next point, visceral organ pain and acute abdomen. Visceral organ it means internal organ like a chest and like a abdomen and pelvis lead to pain. Understand? Next point, subarachnoid hemorrhage. Subarachnoid hemorrhage. Subarachnoid hemorrhage, bleeding between the arachnoid space. Arachnoid space is a pia mater and arachnoid matter. It is called, understand? It is called arachnoid space. Bleeding is bleeding between the space of arachnoid space or arachnoid space, arachnoid matter and pia matter. Understand? Next point, pneumonia and pleurodenia. Pneumonia is a inflammation of lungs. Inflammation of lungs, parenchyma, causative agent bacteria, virus and fungus. Pleurodenia. Pleurodenia is a Pleurodemia is a infection, viral infection that affected of muscles and caused by the stabbing pain in abdomen and chest. Understand? Next point, peripheral neuropathies. Peripheral neuropathy, all are known. Peripheral, all are studying in MSN. Peripheral neuropathies in a numbness and weakness of weakness usually in hand and foot. Understand? Next point, endotracheal tube suctioning. Endotracheal tube suctioning, if a patient having any obstruction, any cardiac, any respiratory condition, then going to endotracheal suctioning lead to pain. Next point, repositioning. Repositioning, change the position, different position, change the position, then easy for the patient. Next point, physical therapy. Physical therapy stimulate the body movement and stimulate the stimulate the muscles relaxation. And next one, monitoring device. Monitoring device, all are know device. Next, we will discuss about difficulty in pain assessment and management in ICU. Unable to communicate. First point क्या है? Unable to communicate effectively. It means those are admitting in ICU, patient is not able to communicate. Next point, cognitive impairment. Patient cognitive impairment, it means unable to think, unable to learn, unable to confirm any memory. It means next point, sedation. All are known as journal. Journal terms in sedation, calm, calming, calm, relaxation. Next point, paralysis. Paralysis, all are know temporary or temporary or permanent, not movement of muscles. In voluntary muscles not respond. Next point, mechanical ventilation. Mechanical ventilation, it means those are patient not able to take breathe, give ventilation machine to help the patient for breathing. Next. Potential consequence of poor pain management. First point, patient feel of powerlessness. Patient, if patient not proper give management management of pain, patient heal weakness, not power satisfy. Next point, suffering. Suffering in problem, creating suffering in disease condition, any illness. Next, mental status. Mental status also will change. Next point, agitation. Patient hesitate, confused, disorientation. Next, delirium. Delirium is a confused disorientation, mental status change, confused and disorientation, not able to think about these things. And next point, psychosis. Psychosis is a mentally illness, severe mentally illness. Patient is a whole personality in next point, occurrence of psychological stress. Psychological stress, patient having any disease condition, person has take physically stress. Next point, post-operative complication. Post-operative complication after surgery, after any procedure, person get complication. Next, basis fact. Exclusion of warning signs. Reduce, it means reduce warning signs. Avoid warning signs. Next point, goal of sedation and analgesics should be established. Analgesic, establish, develop, analgesics are developed. Next point, exclusion of treatable causes of discomfort. Causes, patient having any discomfort, any problem, it is a treatable. Treatable is a treatable is the most important. Priority of pain management is highlighted. Highlight first priority to pain management is highlighted. And next point, reassessment of sedation and analgesic. If I'm giving any patient medicine, sedate and analgesic, reassessment. Again, repeat and ask to check again. Next point, analgesics are not 100% of sedative and vice versa. Analgesic not 100% treatment of pain. Next, we'll discuss about guideline benefits. First point, evidence-based practice. Best practice, standardized care, reduce variability. Next, reduce complication. Next point, can decrease cost. Evidence-based, best practice. Those are giving care have best practice. Next point, standardized care. It means quality care. Given patient give to quality care, then patient is relief pain. And next point, reduce variability. Variability changes, reduce changes. Next point, reduce complication. Complication reduce, then will patient is relief pain. Next point, can decrease cost. Those are patient having any problem, not afford to medicine, it is costable, then patient is able to purchase. Next, drug. Drug in a WHO analgesic ladder. According to WHO ladder, first non-opioid like a paracetamol, ibuprofen, diclofenac, meloxicam, and naproxen and indomethacin, like a drug, non-opioid drug given to patient having any pain, give to uh, non-opioid drug comparison than opioid drug, low potency of side effect. Next, opioid for mild moderate pain, like a codeine and dextroproxyphene and tramadol and tempatodol. It may comparison the non-opioid and opioid. Opioid is a more potency and more side effect there. And next, opioid for moderate severe pain. Patient having more pain, then uh, then refer to this medical morphine, fentanyl, and methadone like a drug. Next, adjuvant analgesic, tricycling antidepressant and imipramine and imipramine and anticonvulsant and carbamazepine valproate like a drug given to like a pain psychotic like a delirium, dementia, and antidepressant like the condition occurs, also pain occurs na. So then these medicine giving to like a patient antipsychotic antidepressant. Next, we'll discuss about sedation. Sedation is a journal term that refers to the calming of a ICU patient with the use of medication. Sedation is a journal term calming in calm and relaxation of muscles. Next, due to a critical illness or injury, an ICU patient may experience an unpleasant feeling, anxiety, agitation, fear, or pain. In addition, some of procedures and supportive care such as a mechanical ventilation may make a patient feel comfortable. Any patient having any critical injury, provide sedation, analgesic, patient will reduce pain, anxiety, and pain also. Next point, the ICU staff will attempt to comfort patient by speaking to them and by resuming them. It means any patient in admitting in ICU, ICU provide analgesic to relieve pain and stop also relief. Principle of sedation and analgesic. First, consider individual patient characteristics when selecting analgesic and sedative medication. First point, correct underlying condition. Correct the condition of the patient. And next point, considering underlying metabolic static and capacities. It means metabolic system is correct. And next point, considering adverse effect of sedation and analgesic. If I'm giving any patient sedation and analgesic, check the side effect. And next point, using a algorithm or a guideline to assist the practice. If I'm giving any procedure, any medication, and check how many mg give to patient, and rule regulation, follow the rule regulation and mathematics use, then will give to patient. And the next point, using an tool to assess sedative pain status. Check the pain status of the patient. Next point, promote several questions relate to patient characteristics. When next point, when, how to do, what need to do. It means if I'm asking patient, if I'm giving anesthesia and analgesics, asking question na characteristic, any symptoms occurs or not, any what to do, what to do, how to need to do. Next, algorithm for the pain and sedation of mechanical ventilation patient. Patient having ventilation and give the sedation to relieve the pain of the patient. Next, non-pharmacological intervention. Non-pharmacological, it means I'm not giving treatment, medication. Without medicine, how to treat the patient. First, exercise. Exercise, all are know exercise will reduce the pain also. And dancing therapy. Dancing therapy, if I'm giving patient having pain, doing dancing will reduce the pain. And weight reduction. Some person having more weight lead to pain. To avoid the say to patient and avoid the weight overweight. Next, counseling. If any person having more pain, and if I'm experience our communication and give to counseling the patient, then release to pain. Next, smoking cessation. Some person are taking smoking, tobacco, alcohol to guide the stop the smoking and alcohol and tobacco. Next point, massage relaxation therapy. Massage relaxation. Any patient having pain or in any, then will give to massage therapy to improve the pain and reduce the pain. Next, heat and cold application. All are no heat and cold application. All are taking hot water bag, and if having anyone menstruation pain, any and other pain will reduce to if I'm using hot water application and heat application to reduce the pain. Next point, music therapy. Music therapy, if a person having any anxiety, any pain, any emotional status, will give to a person have reduce the pain. Next, deep and slow breathing. Deep and slow breathing, one type of exercise, reduce the pain. Like massage relaxation therapy, counseling, deep and slow breathing. Music and dancing therapy. What are the important non-drug treatment for already these things comes under exercise and summary. Introduction, definition, and pain in ICU, difficulty in pain assessment and management ICU, and next potential consequence of poor pain management, basic fact, guideline, benefits, drug, non-pharmacological intervention. What are the important non-drug treatment for pain relief? Here the summarize. Conclusion. Conclusion, adequate pain management often reduce the need for sedation. If patient having pain, give analgesic, reduce the pain, and avoid the mostly avoid the sedative drug like sedation. Narcotic based sedation such as fentanyl or morphine compared with the traditional sedation benzodiazepine plus analgesics for pain may result in a true patient outcome. If I am giving sedation and analgesic, patient condition is improved.
Thank you so much, Ms. Priyanka, for your enlightening talk regarding pain management. And you have rightly pointed out they play a key role in the patient journey. Now it's a time for lunch. Okay. Thank you, everyone. Please come to after 1 hour. 2 o'clock. पे
This recording will be resumed after 1 hour. So till then the recording has been stopped. So we will meet after 1 hour. Thank you.